Insurance Committee meeting of July 27th, 2023 to order. If Susan, you'll call the roll, please, ma'am, I would appreciate it.
Yes, sir. Commissioner Boyd. Here. Amber Brown. Here. Suzette Couples. Here. Holly Deering. Brian Gaither. Mary Hickerson. Here. Lois Miller. Here. Commissioner McAdoo. Here. Commissioner Phillips. Present. Shantae Sherrill. Michael Smith. Here. Steve Spence. Sonia Stevenson. Eric Tutobeni.
Thank you, Susan. Now we have the approval of the minutes. Ms. Hickerson, do you have you reviewed the minutes, please? We have a motion to approve the minutes. Do we have a second? We have a second. All those in favor of approving the minutes say aye. All those opposed? The ayes have it. The minutes stand approved. Through this point in time, we come to the public comment section of our meeting, and it's my understanding, Susan, nobody has been asked to speak. Is that correct? So we'll move on to item 4, financials. Mr. Elam, you're recognized.
Yes, sir, Chairman Carr. For the month of May, in the 264 fund, revenue is $1,754,280. Expenses, $1,772,731. Revenue less expenditures, a negative $18,451. And for your calendar year total, for revenue, $10,470,755. Expenses, $14,880,533. Revenue less expenditures, a negative $4,409,778. And for the fiscal year, totals is revenue $48,755,595. Expenses $55,918,721. Revenue less expenses, $7,163,125 with a negative. On the 266 fund, for the month of May, workers' comp, $715.82. OJI, $101,635.21 for a total of the year to date. For workers' comp, $1,359,673.13. OJI, $570,570.54 for a total of $1,930,243.67. And that concludes my report, Mr. Chairman.
Any questions for Mr. Elam? Yes, Ms. Hickerson, you're recognized.
Yes, sir. Ed, could you do a little explaining on, I know the money is different when we look at Susan's OSHA report, and there was only 8 for, oh no, I'm sorry, that's June. But anyway, can you tell me why we're at 101,000? Is that because of the number of incidents we had for May, or did we have a claim that stuck out that, you know, we're finishing up on, or they actually had something? And I know there's only so much information you can give, but we took a huge hike from 62,000 to 101 from April to May.
Yes, so for the month of May, that is the claims that came in for the month of May. It was just, like I said, that was the claims that came in. Some of them are delayed. Some claims may be 2 or 3 months old, and then you may, but most of your claims come in within 60 days. But every now and then you can have a lagging claim, and then that's the type of claim that you may have for a particular person, the severity of the claim.
Okay, so it was not one thing substantial that maybe we need to look at in one department that might help other departments to, you know, if it was an accident and that could have been prevented, or we need to change the way we've done something. So this is just more or less claims coming in, and nobody, or no 1 or 2 or 3 incident that changed.
Correct. And while we're on that subject, one of the things that the office has concentrated on for the last year or so is trying to get better training out there, trying to get in our departments, some particular departments not a fault, but just better training. And I don't think we've been back since Susan has gotten her certificate, but she has now gotten a certificate to be able to teach the 10-hour OSHA class and the 30-hour OSHA class. So we're hoping these numbers will go down. I think if you look at the numbers compared to the total number, if you look at the year-to-date compared to last year and the year before, you will see that there is still an increase, but also, like 21, 22, 2021, those were some COVID years, so you also had teachers out at that time. So that number looks like there's an increase, but when you compare it back 3 years ago and 4 years ago, it's more of an accurate comparison than those COVID years.
Any other questions? I have one for you, Ed, if that's okay.
Yes, sir.
So I'm listening to you go through all these numbers, and some of these numbers are pretty big. And so not for today, but at the next insurance meeting, I guess I want to know, and don't just say yes because I'm asking, because I genuinely want to know, could you kind of give us a brief summary of with regard a comparative analysis about where we stand from previous reports, and can you just kind of give us an assessment about how we're doing in these regards and things that we might want to take a closer look at as opposed to just giving numbers, because I would like to see some of these numbers have some meaning with regard to previous reports that you've given. So I guess what I'm looking for is a little more commentary from you, since you deal with these numbers on a daily basis. Is that something you could provide the committee? And quite honestly, I would like to hear from the committee if that would be something that would be of importance to you as well. I don't want to be the only one here saying, hey, I'd like to know a little more context about these numbers and what their actual meaning to the county is. Well, Commissioner Phillips, did you want to? You had that look like I'll chime in at this point. You recognized.
It's kind of an age-old question, and Ed and Susan probably both know exactly what I'm going to say, but there's an industry standard called TIR, Total Incident Rate. That's a standard rate for any particular industry or company. Government's a little different, but still there is a total incident rate. We calculate that total incident rate, and that's a much better gauge of how we're doing month to month and year to year versus the total numbers, because as employees go up, our liability goes up with that, and cost is really not a good comparison, because you can have a low number of injuries, but one that is substantial that cost you millions of dollars. So the total incident rate is something that if we gauge that on a regular basis, we'll know whether we're performing the same, better, or worse than months in the past or years in the past. So that total incident rate would tell us everything that you're asking.
Correct. And one of the things we've looked at is trying to get it maybe a quarterly total incident rate, but it requires man-hours worked from the finance office, and Susan's been in contact with them, and so in order to get that number, it takes a lot of work to get it quarterly. They have to provide that number, and that's why we have it, that total incident rate at the end of the year. We get it annually. State of Tennessee, theirs is usually, by the time we get it to compare Rutherford County to the state of Tennessee, their number is like 18 to 20 months behind when we get it. I mean, we can do hours in a short period of time for the annual once we get the number. It's just putting in the total hours worked, number of incidents you have, and then I think it's divided by 200,000 man-hours, something like that. But to get that rate. But to do a comparison, we always have used the state, and we're still below the state rate, what they look at. But we've tried to we've talked to finance and trying to work through what it would take in order to get it maybe quarterly for this committee. But right now, we're,
So I think I now truly regret having opened this can up.
no, I mean,
Because I'm looking at Director Michael Smith back there. He just literally put his head in both of his hands and just like, oh, why didn't the mayor talk to me about this before he brought it up? So it wasn't my intention, Director Smith, to drag you into, and your department doing any more work than you're already doing, especially this time of year. So I was just looking for some context to the numbers and how, like Commissioner Phillips said, how we were doing comparatively speaking. I wasn't looking for any type of additional workload, so my apologies in that.
I want to just expand. We do, look at it on a yearly basis, but because it fluctuates so much, it is hard for us to look at it on a quarterly or even a monthly basis because of fluctuation. And I'll give you one example. So if you're looking at the 266 report that's on your iPad, you're going to see August, you're going to see a workers' comp claim of millions more, like we said. So that quarter would not be as comparison. Now that was something we paid out from years ago that we were expecting. We had already accounted for that on the balance sheet. You won't see that here, and I think we could definitely give some context to that.
And that's exactly that's exactly the kind of information I thought might be relevant.
So that's why you see 2022, 2023 to be 1.9 million, and the rest are 500 or 600,000. We are in comparison with other years if it wasn't for that one large claim. However, one of the things this sheet doesn't show is that we accounted for that claim already on the financial statements, and so we had been planning for that, and it did not. It had an adverse effect, but it wasn't an unknown, unforeseen, unplanned adverse effect. And so I think we could add that context, but as far as something on like a monthly or quarterly basis, it's very hard for us to get that turnaround time to them. The lag is so long that it wouldn't be a great comparative analysis, especially if it was something like that, which is kind of why we try to do the yearly. And then I'll add, the reason you don't have June on there is because we anticipate closing the fiscal year first of next week, and then so me and Ed have already talked that I'll have his year-end numbers hopefully before budget, and then I'll give budget and the commission a August report that will have some of this, but then I think Ed will be able to come back at the next insurance committee meeting and be able to give a year-end comparative total.
yeah, next meeting we'll have June and July report.
Thank you. Any other questions? If not, I'll entertain a motion. We got a motion. We have a second. All those, we're going to do a roll call vote. Susan, thank you.
Commissioner Boyd? Yes. Amber Brown? Yes. Suzette Couples? Yes. Brian Gaither? Yes. Mary Hickerson? Yes. Lois Miller? Yes. Commissioner McAdoo? Yes. Commissioner Phillips? Shantae Sherrill? Yes. Michael Smith? Yes. Eric Tutobeni?
Yes. Thank you. OSHA report, Susan.
You'll have May and June on your iPad because we didn't meet last month, but I'm going to go over the June report. For June, we had 8 incidences. That brings our calendar year-to-date total to 121. Of that 121, there were 80 that were OSHA recordable, with 11 lost day claims, 52 restricted day claims, and 17 other recordables. On the next page, you have the total year-to-date comparison of 2023 at 121 to 2022 at 85. In 2021, there was 89. The next page is the incurred dollars. Mary, just real quick, the difference on this, because you've asked a few times, is the incurred dollars is the amount that the third-party administrator automatically assigns when they initially receive a claim. So it's just a obscure amount that they think that claim will cost. And then the 266 is actually from the check register what we paid out. So those claims could be from several months behind, like Mr. Elam said. So for 2023 up through June, we're at $433,000 compared to 2022 at $308,000 and 2021 at $366,000. And the final page is the breakdown of the 8 claims, with 4 being at Board of Ed, 4 at County General, 3 at the Sheriff's Department, and 1 of those for County General was at Correctional Work Center. And that concludes my report.
Thank you, Susan. Any questions for Susan on the OSHA? Seeing none, I'll entertain a motion. Got a motion. Do we have a second? All those in favor say aye. Opposed? The ayes have it. We now move to item 6, wellness update. Ms. Lovett from Cigna.
Good afternoon. So our wellness update for our incentive points, where everyone is, compared to last July at the same time, and these are filtered out for the Board of Education, has been filtered out for the comparison. Right now we are at 502 compared to last year we were at 480, and that is for everyone that's got all 3 incentive points. The monthly podcast communication, in July we sent that out as usual. It was for UV safety awareness, and going into August, the first of the month, you will hear a new one talking about some of the national awareness habits and starting your day off right for physical nutrition and occupational health. Next, I will be having a third quarter wellness challenge coming up for our third quarter, and that will be healthy habits and better breakfast. That will be coming up and starting end of August is where we'll start it. It'll be a 6-week campaign. The challenges have gone well this year, so I'm looking forward to our third quarter one. Currently, we are out doing our Wellness on Wheels. We do this every year, and this has been our best one yet. We've got to reach out to some new departments that we haven't seen. We have doubled our participation, and also just people knowing more this year, people engaging more, asking questions, and just already knowing what to do has been a great thing. So we are still on our 4th week of that. We have about 1 more week left of a couple more departments to hit. And also in the month of July, the very first week, we did the Cologuard campaign to people that qualified for that, and that was something that was sent out to everybody the 1st of July to prevent colon cancer. And that's where we at for this month and last. Any questions?
I have a comment.
I'm sorry, you're recognized.
All right, thank you. Going to your Wellness on Wheels, everybody knows I'm at the highway department. You got bush hoggers, you got pavers, and you got dump truck drivers. And we're a small department, but I want you to know Liz and Lee come out last Thursday on the 20th, and we had a great turnout and response from the guys. I think y'all got there maybe about 4 o'clock or something. So it was the end of the day, and great response. They come in, was checking on their points. They were able to ask Lee questions, and they had somebody to talk to for questions and somebody to see and talk to on their points, so that they're not charged the $25 on their premiums and everything. And they even liked Liz come up with a drink, a juice, lack of a better term, a Gatorade.
It's the healthy version of Gatorade.
A healthy version of Gatorade, and some of the guys was wanting the recipe. Yeah. So that should tell you that they are out and they are doing good, and they come to the highway department, and we had a good response from our guys. So thank you for that, and for the departments that have not had you yet. It's a good thing, and we do appreciate it. So we do appreciate you and Lee coming and answering our questions, anywhere from checking, like I said, checking points to actually having questions about claims and things like that. So I just, a good old pat on the back and attaboy doesn't hurt every once in a while.
Thank you, Mary. Commissioner Phillips, that would qualify as a shout out, wouldn't it?
Absolutely.
Commissioner, the commissioners know what I'm talking about. As the chairman of the commission, I concludes every commission meeting with something that's being done within our community that's particular significance that needs recognition. So that's what that is.
Let me follow up with a double piggyback on that shout out. If you look at the OSHA report month after month after month, those highway employees are in a position to where they put themselves in a more dangerous situation than, and I'm not going to say the school teacher doesn't, but then a school teacher does. But month after month and year after year, you see zeros as far as accidents in that department. That's the type of performance that we're looking for. And I don't know how to shout it out any louder than that, but that highway department, with the type of physical work and engagement that they do, has almost a perfect safety record. And one of the reasons for that is because the manager of that department and the employees of that department put safety above anything and everything else. And that's what has to happen.
Thank you, Commissioner. Thank you very much.
I will say it has been really great. The more we have got to go out in the last 2 years, the biggest benefit has been getting to know the departments separately, not just everybody's an employee, but separately, what they do, what kind of questions they have compared to another department because of what they do and what they deal with. And it has helped us come up with better ideas to get them to engage. For instance, guys coming out from a long day, they, instead of drinking sodas and energy drinks, maybe we can introduce them to something else that will bring down a lot of blood work issues, I'll just to say. So it's helping us learn the departments, and it's been great. And thank you very much for your compliment. We truly appreciate that. Any feedback?
No further questions with Ms. Lovett, or comments or shout-outs? Thank you.
Thank you.
Item number 7 is the MedPoint Report with Ms. Beth Wilson. Ms. Wilson, that's a hard act to follow.
Good afternoon. I'm going to be reviewing the May and June data for the MedPoint Clinic with you all today. If you can turn to page 3. The visit summary. In May, we had 167 visits, and in June, 177, with 141 of the visits in May being unique members, and in June, 146 being unique. Both May and June saw an increase in visits from April. Also, if you compare to the same months in 2022, there was an increase in usage of the clinic as well. On page 4, the visit summary by member type. In May, we saw 27 children, which made up 16% of the visits, 116 employees, which made up 70% of those visits, and then 24 spouses, which made up 14%. In June, we saw 23 children, which made up 13% of those visits, 132 employees at 75%, followed by 22 spouses, which made up the final 12% of those visits. On page 5, the visit appointment type summary. In May, we had 20 members that had 2 to 3 visits in our clinic. And in June, we had a total of 25 members that had 2 to 3 visits for varying reasons. On page 7, the visit summary by day. There were 22 scheduling days in the month of May. Monday, Tuesday, and Thursday were equally busy in that month. Of note, there was a holiday, Memorial Day, in May. June also had 22 scheduling days in the month. Monday was the busiest day in the month of June. On page 9, the in-person versus virtual appointments, you'll see that we saw 3 virtual visits in the month of May and 2 in the month of June. So as you can see, we're seeing less than 2% of our visits virtually. And again, that is by choice of the patient or the type of symptomology they may be having. On page 10, the in-person versus virtual appointments. Although our virtual appointments have never really been high, you can see that they continue to stay below that 2% since around March of this year. On page 11, our referral summary for May, there were 21 referrals. As you can see, orthopedic referrals continue to show up in our top 5. June, we had 17 referrals. Again, orthopedic was in the top 3. And then the financials for May and June. May, the operating cost was $60,264.60, with 141 unique members being seen, a total employee count of 1,937 for a PEPM of $31. Of note, there were 3 pay periods in the month of May. There were also a couple of large invoices that actually paid out in May, which kind of accounts for that higher dollar figure. In June, there were 146 unique members. The total operating cost was $31,174.78. Employee count was 1,938 for a $16 PEPM. Our population health analysis on page 16. In May, females' highest BMI was in the overweight and obese class 1 category, and the males' highest BMI percentage was in the overweight category. In June, both male and female BMI was in the overweight category. On page 18, the diagnosis codes. Encounter for general medical exam and type 2 diabetes hit the top 2. We're finally seeing pharyngitis and sinusitis fall out of the top 2 in these last 2 months. In June, encounter for general medical exam and anxiety disorder were the top diagnosis for the month. June did see a significant increase in the number of physicals. We have seen a steady increase, but as you look at June, you can see that 28.19% was pretty significant. On page 20, the visit demographic summary. In May, 60.48% of the members seen were female. The female age range was 50 to 59, and the male age range was 40 to 49. In June, 56.57% of the members seen were female. Both female and male age range in June were 40 to 49. Again, we continue to see that the female population uses the clinic, has a higher usage in our clinic. And that concludes my report for both May and June.
Thank you, Ms. Wilson. Any questions? Yes, Mary, you're recognized.
Thank you. In June, with the encounter for general medical exam being up to 28.19%, might be putting you on the spot, and you may not know the exact answer, but is this due to an increase of everybody realizing they got to get their points? And am I remembering correctly that even our athletes can get sports exams in that? So is that kind of part of this increase on that, or we got folks just finally getting in and seeing doctors for other things?
So I think it's a combination of both. Most definitely, people are trying to get their points, for sure. And yes, we still do offer the sports physicals in the clinic for anybody that would like to use those. So I think you're seeing a combination of both people trying to get their points and then, of course, new employees that are making appointments and getting their care that they need.
Thank you.
You're welcome.
Any further questions? Seeing none, thank you. Item 8 on our agenda is, without coincidence, the MedPoint clinic discussion. Mr. Elam, I think you've got some things you want to share in that regard.
Yes, sir. So where we're at right now with the clinics is we're either at time to put out an RFP, continue with the same model we've got, change the model, or change take a look at how we're doing, what we're offering to the employees, and is it the most return on our investment, the best return on our investment. So what I'm bringing before the committee now is, at this point, we have 120 days to offer to Ascension St. Thomas anytime that we decide to cancel our contract. And if we put out an RFP, we would have to give them that 120-day notice. Because if the RFP started in 120 days, then they would need to be aware that the contract is ended and that we've moved to a different vendor if that was the case, or stay with them. And because the schools left, we went from 3 clinics down to 1. And so part of the issue is utilization. If you look, go back to the report, and I think it's page 7, page 8, page 7, I believe. Yeah, so when you look at the average patients seen per day, and you look at 8, 8, 7, 8, and 7, those numbers should be quite a bit more. Matter of fact, a lot more. And, you know, the question that we asked, and one of the things we wanted to do is give the clinics an opportunity once the schools left and we got down to 1 clinic, is what was our utilization with our county general employees? Would we see the viability of the clinic in the Salem Road? And at this time, we leased the space from Ascension St. Thomas for the 1 clinic that we're in on New Salem. So when you look at these average appointments seen per day, then when you look at the amount of money that we have, we're approximately, and it's just a rough estimate, but annually it's going to be about $525,000 to $550,000 what is going to be the annual spend on the clinics. What I will also keep you in mind is that if you say, well, if we do away with the clinics, it'd be a savings of $525,000 to $550,000. That would not be true, because all of those people that are at the clinics would now be going somewhere else, and they would be creating claims at a different facility or different provider. So there wouldn't be, I don't want to mislead you to say that, you know, if you did away with them, that's $500,000 you could save. It's just not true. So part of the analysis that we're trying to do is, you know, what would that be? How would it look at, you know, what other options do we have? Take somebody that's in the Laverne, Smyrna area. Not a lot of those people travel to the clinics in order to use the clinics. And I wasn't here when the clinics were put in place, but one of the things, the clinic was done for convenience, and there wasn't a lot of walk-in clinics that you have now in so many different places. So it helped for the convenience and helped get people into the clinics quicker. My biggest concern is, you know, the money that we're spending on personnel is a set price. Basically, you know, we're doing like a cost plus basis for management fee. So that is a monthly fixed cost. And so your per employee per month will go up and down based on the cost that's involved. Now, your variable cost is, as Mary was bringing up, supplies, things like that. You know, if you have biometric screening, then your supplies are going to go up, and that'll be the biggest difference. And then I think in this last report, it also depends on like labs. When labs come in, if it hits 1 month or you have it hit in 2 months, so it'll raise that total cost that month up. And you can see when you look at your cost from the month before, you see you're in the 30s, and then this month is in the 60s. So that's part of that overlap between 2 months. So what I've asked Gallagher to do, and I've asked Marissa to come up and kind of speak with her experience on the clinics, and just kind of give us an overview of what we want, how do we want to move forward, and the model that we have. You know, do we still want to continue with what we have or look for some other options? And so if the committee doesn't mind, I'd like for her to come up and just kind of give you her experience with some other clinics and some other ideas that we've got on the table.
Without objection, Ms. Smith, come forward.
So, without really having, you know, a set preparation speech on this item, we have met internally at Gallagher. We have an expert who is a wellness and clinic management type of specialty. She's worked on the clinical side, worked on the carrier side, and now works for Gallagher. She really helps evaluate modes and methods of care, right? So including worksite clinics, that's one of her specialties. We've had some meetings with the risk management department as well, just to kind of talk about what would be appropriate levels of use for sustainability and for really driving impact to the plan. We've met with our actuary to talk about, the actuary that's working on Rutherford County's case, to talk about what you would expect to see turn the needle in terms of a dramatic ROI, where it would be something you'd want to sustain from that perspective. So looking not only at the cost out the door, but when does it start to manage the plan in a meaningful way? A couple of observations about that. From a statistical perspective, we typically would see the turning point of whether a clinic is viable be around 1,400 employee lives. Y'all are, a little below that, but you could keep a benefit like that if you thought that it was driving behavior in a significant way that would really impact the plan. As I have further learned and talked with the folks that do this a lot, the number that they sort of target for a really strong performance of a clinic would be somewhere between 25 to 30% utilization. You guys are hovering at around 7% on your own merits. So no accounting for school system, really stripping it down and looking at what county employees and their families are using. And that's 20% based on the number of eligible people to use the clinic, so not just employee lives at that point, right? If we take the employee lives, that would be a higher percentage. 7% would move the needle. I didn't do the math, but considerably, because the majority of who's using it are employees. So with Gretchen's assistance, what we have started to explore is, and also with a lot of assistance from Cigna, we're in the shout out mood today. I'm gonna give a shout out to Paul and his team, because they have been really good thought partners with us around what the plan already covers, and what we could migrate the usage of for those who do depend on the clinic, to make sure that there aren't gaps in care and that there aren't places where people maybe have hidden things going on, but they don't know where to go, and so they just don't treat, and then it's more catastrophic. So we're mindful of those things, and I think just from a trajectory perspective, really looking at using more, and you have a really good utilization already of MD Live. From a statistical perspective, Paul and our team are pretty happy with the usage rate, and I think risk management's pretty happy with the usage rate of that. But just making sure employees know that they can go to that as the next point of care if they're really trying to find something quickly. And then a huge key piece of this that we're working on is analyzing the community care clinics. So that is a meaningful term within the Cigna arrangement in the market, where they have contractual agreements with certain clinics called we call them CCCs, so community care clinics, and those are your Kroger, your CVS, Walgreens, which includes the Vanderbilt clinic that's inside of a CVS, but it does not include a standalone Vanderbilt clinic. So let me be clear about that. But it includes some of those levels of entry that people who live in Smyrna or live in another county but work for you would more easily have access to something now than maybe when the clinic was originally placed. So through a combination of those community care clinics and the education around those, a few years back, another important point on that is, a few years back, before our time with your account, the decision was made to reduce the number of clinics, I think, from 5 to 3. And at the point that decision was made is when I understand, and Paul could speak to the specifics better than I could, but that there was a shift made in terms of who could get coverage at the clinic and at what percentage of care these folks could get. And then taking that argument and looking at the clinic, the CCCs that I mentioned, the Kroger clinic, the CVS, Walgreens, those types of places, they can, except for HSA participants, and that's an IRS rule, not a Rutherford County rule, all the other plan participants are able to use those clinics and have 100% coverage for those clinics, is my understanding. So, that's another migration point that I think we just need to do a really good job of education. I don't know if that's what you wanted.
Yes, you did a very good job explaining it.
I'm happy to take questions too. So.
Mary, you're recognized.
Okay, thank you. All right, to go back to your CCCs, and I think we may have to bring Paul up and ask, but even with this clinic we have at New Salem, we have always had the ability through our relationship and our contract with Cigna that we are able to stop at the Walgreens or the Kroger's for them to have the same type coverage, and I want to thank at zero, except for the HSA.
The HSA is the carve-out.
Yeah, and like you said, that's our IRS. So in thinking out loud and doing this, my guys some of them utilize this walk-in clinic, and in times past and in recent, we have had trouble with certain things. We've been called and gotten those worked out with the clinic and everything, but maybe in all fairness to the employees and trying to be good stewards of their money is to rework and cancel what we got and rework and put out for an RFP. When we do an RFP, if I'm not mistaken, it doesn't mean we have to do it. So it may be that we rework what we think will be the best for our 1,600 lives that there are now. And because if I lived in Laverne or Smyrna, I wouldn't pass a Walgreens to come over to New Salem if I'm still getting the same care, the ability to get a prescription. Of course, prescriptions cost you, but the same care at a zero as if you come over here. And some of my guys have been able, with the work of the clinic, to work into a doctor's situation, that they're not just totally getting care. So I really think that it might be the time, now that we've come down to here, we've had a year of close to a year of knowing what it's going to cost us, but mainly to make sure that what we have with Cigna could offset the ability for our guys to walk in, or guys and gals, to walk in over at New Salem.
Yeah, so I'll maybe...
If you will state your name and who you're with, please.
Paul Huffman with Cigna Healthcare.
Thank you, sir.
Good afternoon. So just to simplify it a little bit more, Mary, and what you said was exactly right. What Marissa said was right. We contract individually with what's called convenience care clinics. So you were close. It's and I wouldn't make that correction except for the fact that when you are actually searching mycigna.com for providers, they come up under that title. So they're actually called convenience care clinics, and that's very specific to the Little Clinic, Minute Clinic, and the Vanderbilt clinics inside the 3 drugstores, okay? And that's the only 3 there are. The good news is, in case you're not aware, and just like Mary said, today you already have those 3 clinics covered in your plan at 100%, meaning there's no cost share. People in the OAP copay plan and the deductible plan can go to those 3 clinics anywhere in Smyrna, Laverne, Murfreesboro, Nashville, anywhere in the country for free care, zero cost. And then those that are in the high deductible plans, the HSA plans, their benefit is slightly better, but they are required to meet their deductible first. But after they meet the deductible, they get 100% coverage, so they don't have that 80% coinsurance. Mr. Tutobeni? That's what we're talking about. Yes.
Well, and
Excuse me.
That's correct.
Excuse me, Mr. Tutubeni, if you could use your microphone, we would appreciate that. Thank you, sir.
Should I say that again?
Sure.
So those are the clinics that are in Kroger. So Laverne and Smyrna do have the little clinic already.
They do.
and we have Walgreens and CVS also, but I'm not sure.
That's
what
correct. So I think the common theme here is that there's an opportunity to leverage those again, for more education, more communication, to leverage those, in the absence of an on-site clinic. And then, as Marissa mentioned, we have another tool in our toolbox for MD Live, which is telehealth. An even lower cost option that we can discuss and look at, which a lot of our clients are moving more toward that as a first step in care as well. So does that help?
Yes, and just to clarify one thing, he said 3 clinics. It's those 3 providers with 3 brands with multiple clinics.
Correct. Multiple clinics, 3 brands. All of them are contracted that way. So they're contracted individually because they're a lower reimbursement, and that's why the county several years ago said we want to be able to have those included at a better benefit than other places. So
On the MD Live thing, I know there was some discussion about HSA, high deductible HSA participants. And will you talk about the IRS ruling for 2024?
Yeah. So I had to remember what that was.
We talked about it.
Yeah. So the IRS, during COVID, IRS made some leniency with regards to telehealth, and they allowed telehealth to be used and utilized at 100%, even for people that were in plans, high deductible health plans, and that waiver has now extended through 2024. So if Rutherford County wanted to really increase the benefit for MD Live telehealth visits, you would have that option to make it 100%, just like you have that ability now to do that on the copay plan and the deductible plan. But you would even have that ability on the high deductible plan through 2024, and then to be determined what would happen in 25.
Because the government regulation says you have to, for an high deductible HSA plan, you have to charge something.
You have to have a deductible usually, but we made, or an interpretation that you're charging the, I guess, what the average cost of a service, which is why you were able to put a $30 copay on the MedPoint clinics for the high deductible health plan. Yes, Lois.
Yes, Lois, you're recognized.
This is just a historical perspective. We first put our on-site clinics in the early 2000s. So back then, these convenience care clinics weren't really available to the extent that they are now. And so it's been wonderful to have a clinic specific to the county, but several years ago we had to downsize and go to just one. And again, the location is somewhat difficult for a lot of the county employees to attend, whereas these convenience care clinics are much more centrally located, or I guess the other word is they're out along the perimeter, so that the employees have access to them. I personally have used a convenience care clinic, and back in the day used the on-site clinics as well, and I can tell you that there's not a lot of difference between the care. And so it seems to me that the convenience care clinics would provide the same service as the on-site clinic does. We just have to determine what the cost would be for that versus the on-site clinic. But what I'm trying to say is if we are no longer able to support the on-site clinic, then these convenience care clinics, now that they're here and available, might be a very good option.
Well, and keep in mind, the option is already in place, and there's really no improvement on what you have today. So they're already at 100% for the copay plan and the deductible plan, and the high deductible plan is already at its max. So it's just a matter of now deciding that's what you're going to promote. Yeah.
Should we address the gap?
Yeah. So one of the caveats that I shared was our contract with convenience care clinics does not include preventive care services. Okay? So it does not include biometrics and wellness screenings. Okay? So that's a gap, and we talked internally about filling that gap with telehealth MD Live, which does offer preventive care and wellness screenings, believe it or not, remotely. And for some people, that's even more convenient than going to a convenience care clinic, is to make a phone call with a physician, have that physician schedule their lab at a convenient lab near their house. They make that date and time on their own, schedule the lab, have it done, and then meet back up over the phone with an MD Live physician. So another option.
Yeah, I mean, that's one example of a gap in care that we do want to be mindful of, and we're trying to address the best we can on, like, what do we need to tell folks at open enrollment, because, you know, that's their opportunity to maybe consider other plans and what they want to do. I can just tell you kind of how I manage my own as an example that I think is something that could completely be done under the plan. Of course, this is specific to women, but when I get my Well Women's visit, I also have my blood panel done. And that's a physician, and they go through my blood work with me, and it's part of my annual wellness thing, but it saves me this type of appointment and this type of appointment, I mean, you know, that type of thing. So, I mean, there's some things they can do potentially to be really good consumers as well. And remembering that wellness is always considered preventative, like that screening is always considered preventative, so they're going to be able to get that done without having to pay those out-of-pocket fees at the point of service. So you're not taking anything away on that particular item.
Yes, Mary.
Okay, with going with the preventative, and my thoughts on this, because I've been thinking about it in the clinics. I do think something needs to be changed or done away with, but then my thought was, okay, what do we do with the people in trying to get their points? Because we have a lot of folks that really only go to the clinic, period, one time a year to get the blood work. Well, they go back and get it checked. But anyway, that's all they ever pretty much see a doctor for. So my thought, again, is just putting it out there, is we did a points forgiveness year during the pandemic. So my thought is, for this year, everybody's going to have to finish up by September 30th, thank you, for their points for next year's premium, okay? So we still have the clinic, so we're not hurting nobody. But I think we do look and change, cancel for the lack of a better term, and look in the RFP and come back. But I think we look at the first year being 24 for the 25 of doing a forgiveness on your points so that we can get this in place if we go back to the clinic or we don't have a clinic, but we're able to get the talking points and the paperwork and the whole everything out in front of everybody, that for the next year, go back to your points, but we can tell them about the telehealth of being able to do your your points that way through your blood work and everything. So I really am glad to hear that, because that was one thing that really stuck with me, is how can we do that? And my thought is, if we could do a 1-year forgiveness for the COVID year, we could do a 1-year forgiveness, because the COVID year also had our BOE in it. So if we could do a forgiveness year, just having our county lives, that would give us something to go on. We can really see if a clinic is a clinic that we need, because I really think if there was a way to see Paul's numbers on the CCCs and our MedPoint clinic, I would say we're using the convenience center, the little walk-in clinics, more than we are the MedPoint. So I really, this is really a thought out. I really do think that we need to tell Ascension, thank you for your help, and they just happened to come through with us on the pandemic. So, you know, it's none of their fault. And look and see about doing an RFP, and like I had thought before, and somebody else can correct me, just because we put it out there doesn't mean we have to take it. We can look at the numbers and you know, and even present it to the commissioners and let them have the final say with it. But I think that's how we need to approach this, is to go ahead and look in doing this, and go with the approach of having a 1-year forgiveness so that we can get it out there, get our feet on the ground, and get it to our people if we want to start it the next year, because I truly think it's unfair if we do away with the clinics and not have a true something for the guys to be able to use to get their points for the next year.
So, to address a little bit of some of your concerns, and this is one of the things that we've talked about here with Marissa and Paul, is exactly the same concerns that you have. And how can we address, like the biometric screening, how can we address some physicals? That's the main thing that a lot of people do for their wellness. I do know, I've had some conversations with St. Thomas in the past. They have some buses. We also can set up like maybe a weekend or a day to where the biometric screenings are done in a certain location, like the Ag Center, like quarterly, to where those people that want to come in, you don't want to do it just in the month of August or September, because everybody gets them at different times to get their physicals at different times. So, but as far as like biometric screenings, that's one thing that I think that it would impact the clinics being gone for a lot of people, getting that one extra point at the last minute. So, and again, like I said, that's something we could set up quarterly to see how much of a response we got. There's companies out there that'll come in and do that. We haven't researched it as far as the pricing and stuff like that yet. The biggest thing that I've looked for today is that, you know, with St. Thomas and the clinic that we have on New Salem, we need to give them like a 120-day notice to terminate their, to end their contract, basically. And the reason why we went to December 31st is because a lot of people went in and picked the high deductible HSA plan, and they used the clinics to supplement it. So if you change that in the middle of the year, then it might have an influence on them at annual enrollment, whether they'd want to stay with the high deductible HSA plan or whether they would want to go to the copay plan. So what we're trying to do is get this. There's several steps involved, and the first step is with St. Thomas is to say that we're going to end the contract as of December 31st. Make that decision, yes or no. The second thing is going to be communications for annual enrollment. If you have the clinics, it's a different type of communication than if you don't have the clinics. For those people, they would want to take a good hard look at, without the clinics, what's that additional cost going to be. And for someone, I'm just talking about on the high deductible HSA plan. So that would be the next step. And then deciding on what we want to do on our points, we easily could come back next month and come back with some more information, but I'm trying to do one step to where I don't get too far ahead and we spend so much time in the office pulling all this together, and then it's not the wish of the committee, we've just really spun our wheels. So, and I wanted to get some feedback, and of course, the biggest thing before us today is the contract with St. Thomas till December 31st.
Mary, did you have something else? You got the mic.
If we're to that point and everyone else is through, I'm at a point that I can make the motion to go ahead and cancel the current contract with Ascension St. Thomas for our walk-in clinic effective 12/31/2023 and go forward with an RFP.
Yeah, and come back next month with some ideas, some better ideas.
Absolutely.
That's a proper motion. Do we have a second? We have a second from Mr. Michael Smith. Let's do a roll call on this one, Susan.
Commissioner Boyd? Yes. Amber Brown? Yes. Suzette Couples? Yes. Brian Gaither? Yes. Mary Hickerson? Yes. Lois Miller? Yes. Commissioner McAdoo? Yes. Commissioner Phillips?
Yes.
Shantae Sherrill? Yes. Michael Smith? Yes. Eric Tutobeni?
Motion passes. So you will come back next meeting with Mr. Elam with a recommendation or an RFP? What's our next step in this regard?
Several ideas. Go ahead.
Yeah, I think we are looking at if there's anything to RFP that may be possible. We still have a couple of discussions around that are happening with Gretchen that I mentioned on the clinical side and at Gallagher and what might work. But I can tell you, and I think Paul would probably echo this, we're kind of thinking there are other things you could do that maybe don't actually involve the purchase of something else, but instead the routing of people in other directions. And so, you know, some creative things that can be done with the existing plan parameters and good education is what I'm saying. So we would like to continue to explore that, I think, and come back with more recommendations next month.
Next month.
Yeah.
Any other questions? Ms. Smith, do you have something else you need to say? I think I'm the next. Okay.
I apologize. I can leave though.
No, by all means. Thank you.
So you want me to launch right in?
Yes, ma'am.
Okay, I'm happy to do so. So you'll see one of the other topics we wanted to talk about today is just the stop-loss attachment point. And Cigna, again, another shout out, they were really gracious to give us additional time to study that issue, look at claims as they continue to come in and get a little more history under our belt with the schools being separated out and that type of thing. So important for a committee like yours to know. You are in a position kind of like an insurance company as an employer because you have a self-funded plan, which means always these are questions of risk tolerance. We look at history to predict future, but we don't only get to say history will predict future, right? It's kind of like a 100-year flood. We hope it won't happen twice in some period shorter than 100 years, but it might, right? That kind of thing. So probabilities are something we're looking at when we think about these things, and we also look at the premium differential. So what is the premium for the attachment point of $400,000? What's the premium for the attachment point we're currently at $300,000? As a bit of history, when the school systems were was with you all, you had an attachment point, I think it was $700,000. And that was a bigger premium pool, so, but you also had a lot more people who could potentially hit that max, right? So it was a risk decision then, it's a risk decision now. But having set that stage, I mean, I think the spread between the premiums, if you moved from $300,000 to $400,000, is $256,000. And the difference, though, in the attachment point is $100,000. So that's simple math, is 2.5 times you could take the risk more. We looked at it deeper than that. We ran 1,000 simulations with actuaries to help model out what we think is likely. And again, it's all predictive risk, right? It could get worse, it could get better, but in terms of just percentiles and what we're comfortable with, and then talking with the Department of Risk Management, also had Michael involved for the finance perspective, and I think everyone's consensus was that we would think a move to the 400,000 attachment point is appropriate at this time. So I believe that was the consensus of Gallagher, your finance director, the Department of Risk Management, and of course we'll take questions. I've got more we can say about that, but that's the general thought.
Questions or comments?
If I could just make a comment.
Please.
This
You're
is something
recognized.
we looked at last meeting. In the last meeting, we made a recommendation to stay with Cigna, but we wanted a little more time to study our high dollar claims and then to come back with you this month. So this is the same exhibit you saw at the last meeting. And again, it is after a lot of discussion and talking with Michael, Marissa, Cigna, and myself, with the $256,000 savings. Again, it's a risk. You're trying to predict claim in 2024 that haven't even occurred yet. But in doing the analysis, we feel like that it is worth the risk to try to get some of that savings ourselves.
Michael Smith, you're recognized.
I'll make a motion to approve the $400,000 stop loss limit.
That's a proper motion. Do we have a second? We have a second from Commissioner Phillips. Let's do a roll call on that, please. Thank you.
Commissioner Boyd? Yes. Amber Brown. Suzette Couples. Brian Gaither. Mary Hickerson. Lois Miller. Commissioner McAdoo. Commissioner Phillips. Shantae Sherrill. Michael Smith. Eric Tutobeni.
Motion passes. Thank you, Ms. Smith. We now go to our last item, other business. Mr. Elam, do we have any other business?
No, I've got number, what is it, number 10?
Oh,
Announce the-
my apologies. I'm trying to get us through. You're recognized on item 10.
Yes, announce-
Employee vacancy.
Now, announce county general employee vacancy. Just wanted to put out there for those that are watching that might be interested. The meeting, remember, I want to go over the county commission passed an absentee resolution. Now, the member that has 3 consecutive meetings as absent or a total of 4 absences in a calendar year will be replaced. So attendance is very important for the meetings. In order for an applicant to be considered, they must complete an application, be enrolled in the county medical plan, and submit a letter of recommendation from their department head or elected official with their application. And it must be returned to our office by August the 25th at 4 o'clock. And if you want to email it, it's benefits@rutherfordcountytn.gov. Again, the applicant, if they're not enrolled in the county medical plan, they would not qualify. And, we will stick to that deadline as far as at 4 o'clock. So any late will not be considered.
An email will go out to all county users and department heads with this information when we get back to the office today.
Mary. Mary, you're the gift that just keeps on giving, aren't you?
Exactly. Is this an additional county, or are we going to lose, or potentially lose, Brian or Shantae? I'm just,
It's
I'm sorry, I
Brian's,
don't know.
it's Brian's position. And it's Brian's position.
County employees are for a 2-year term, and his 2-year term ends August 31st.
And then we will come back to this committee to select. This one's a little bit different. The mayor selects some, county commission selects some, the county commissioners that you have, and then this particular member is selected by the committee.
Any other questions? Now we are moved on to other business. Is there any other business? Seeing none, we stand adjourned.